is time for another ultrasound of the week. I'm Dr. Michael Schick. I apologize. I do have a cold, so my voice is rather raspy. We had a great ultrasound this week, a rather challenging one. Elderly male came in with terrible, crushing, radiating chest pain to the back. And I know everyone's already thinking about dissection. You're thinking you want to call vascular surgery, get a CT angiogram, and order blood. Unfortunately, this patient was hypotensive, unstable, and not fit to go over to the CT scanner. Because the index of suspicion was so high, everything was done correctly, and this patient they called vascular surgery. They got the diagnostics they could, including chest x-ray and labs, and they called for blood. And then they jumped in with a point-of-care ultrasound. The first image that was acquired is a subxiphoid view of the heart. Immediately what they see is a pericardial effusion, and then probably either fat pad or coagulated blood. So this is very concerning, either for another etiology besides aortic dissection or an aortic dissection that is now bleeding into the pericardium. This is confirmed again with an attempt at an apical four-chamber view. Here you see again a large pericardial effusion and likely coagulated blood as well. They go down to the IVC because they don't readily see signs of tamponade. In the long axis of the IVC, there is minimal movement and variation in the diameter with respiration. Therefore, I'm sure they were sweating, thinking about how this could be a rapidly accumulating pericardial effusion and impending tamponade. They then went on to the suprasternal view to try to identify a dissection flap. Now, the suprasternal view is one that we don't often do in emergency medicine, although it is one way to try to further evaluate the aortic arch and the branches of the aorta. It's a challenging view because the patient needs to cooperate, and the patient usually has to have a thin neck because you have to put a bunch of gel and then the probe on the top part of that sternum and shoot those ultrasound waves behind the sternum right at the aortic arch. Now, I'm betting when they did this suprasternal view, they were pointing their indicator towards the patient's back or the patient's front, because all the views we see are long axes of the aorta. And as you may or may not know, there are short and long axes in the suprasternal view. When you point the indicator towards the patient's front or anterior or their posterior, you're actually in the long axis of the aorta, whereas you point the indicator towards the patient's right or left, you'll be in the short axis of the aorta. And I know this is confusing, so let's go over the images they got, and then we'll show you the anatomy and the orientation of the probe. So the first image they have, this is the left atrium down here, and you can actually see the aorta coming out, and you can kind of imagine how it's making an arch on the right side of the image here. And there's another vessel you can see, which is probably either the innominate or maybe the subclavian artery there. And the next images we see are really nice pictures of the arch of the aorta, and you can see it branching here on the left side of the image. And the first branch is always the innominate or brachiocephalic artery that supplies the right side of the upper body. And the next branch you see is always going to be the left carotid, followed by the left subclavian. Now here's a picture that really shows the anatomy and the placement of the probe. Notice the indicator is pointing towards the patient's posterior, and it's right in that suprasternal region. And when you shoot down from that top, you get a long axis of the aorta. You can kind of see the arch curving around with the pulmonic artery right below it. And you can see all three branches, including the brachiocephalic, then the carotid, left carotid, and the left subclavian. If you switch to a short axis, when you point the indicator towards the patient's right or left, you're going to get the aorta as a circle, not really getting that arch, but you'll see the pulmonic artery right below it in a long axis, and you may capture some of those branches right above it, and then the left atrium at the bottom. So let's just review this a couple more times. In the suprasternal long axis, you're going to have the aortic arch in the long axis. You're going to see it curving around the right pulmonary artery. Left atrium is going to be at the bottom of the image, and you should see some branches. You don't always see all of them, but that first branch is going to be the brachiocephalic or right innominate. Next one's going to be a left carotid, and then the one following it, left subclavian. In the suprasternal short axis, you're going to see the aorta like a circle, not as an arch. You'll see the right pulmonary artery in the long sort of axis going right underneath the aorta, and then the left atrium at the bottom of the image. You might see the superior vena cava on the left side of the image or the right side of the patient, but don't always see that. When evaluating for dissection, probably the long axis would be the preferred way to go, but you should try to see everything in two planes. So one more time here, here's the anatomy. You see the aorta with the arch here and the three branches, brachiocephalic, left common carotid, and left subclavian. And here our last anatomy picture, side by side, short and long axis of the aorta and the suprasternal window. On the left here, we have that long axis where you can see the arch of the aorta, the right pulmonary artery below it, and the left atrium below that. You can see some branches coming out as well on the top of the screen. And then on the right side here, we have the short axis, which has your SVC on the left, aorta as a circle, right pulmonary artery, long axis underneath it, and left atrium at the bottom of the image. So last notes about point-of-care ultrasound aortic dissection. Use all the windows that you have available. So peristernal long view, you can see the outflow of the aorta. And right there you can often diagnose either an aneurysm or a dissection. Typically, the outflow tract of the aorta is 3 centimeters. More than that, you should be concerned for an aneurysm, and you can measure that easily. And you can often see more of the aorta from this view if you just rock your probe a little bit towards the patient's left shoulder and sometimes going up one rib interspace. Another place we've caught thoracic dissections are actually in the descending aorta on the peristernal long axis, or sometimes even in the proximal aorta in the abdomen, because sometimes it'll dissect all the way down to the abdomen, and that might be where you catch it. Another place we've caught a thoracic dissection is by identifying a carotid dissection. So dissections through the aorta don't have to continue down necessarily to the abdominal aorta. They might go up towards the carotid arteries or brachiocephalix. Now you can see the dissection flap in this carotid artery in the short axis. And then you can also see it here in the long axis, and we add color to this image. And just note that adding color can really help you identify those false and true lumens and should be a part of this dissection study. And then we're able to trace this back to the suprasternal window, and you can actually see this dissection flap going up into the carotid artery. The team here made a valiant effort looking for the dissection flap. Unfortunately, they didn't identify it, and it was later identified on CTA, which just tells you that, of course, ultrasound for aortic dissection, not the ideal test, but sometimes is the best you can do when the patient's unstable. It's better to have some information, especially when there's complications like effusion with tamponade or dissection into the coronary vessels. So it's worthwhile to know how to do this exam, but also know its limitations.